Welcome back to this segment of Ethnic Health America. Our discussion with Dr. Alyce Adams continues. We're going to move from obesity to talk a little bit about diabetes and her impressions of why we're having so much difficulty in certain communities. Thank you again for joining us. Obesity obviously leads us into this whole issue of an obvious epidemic of diabetes in this country. But certain communities are more at risk, aren't they?
No, that's definitely true. In terms of diabetes, around 7% of people in the U.S. have diabetes. But when you look at African American communities, it's more like 12% of African Americans. And it's as high as anywhere to 50% if you take smaller communities, such as small communities of Native American groups out in the Southwest. Some of them have much higher prevalence of diabetes than on average in the United States.
Now, all of that is not obesity. Some of that has got to be genetics, obviously.
Right, and so I think there's a lot of different theories about why diabetes has come to the fore, particularly in certain communities. For example, in the Native American context, for a while there was a lot of discussion about this idea of a thrifty gene hypothesis. And the hypothesis here was that Native American communities were largely living off of healthy foods, healthy diets, lots of exercise prior to their removal to reservations. And then when they were removed to reservations and when certain other events happened that cut them off from regular food supplies, regular water supplies, and they became more dependent on the United States government, essentially the military, to provide food to them. The foods that they got were very highly caloric, lots of sugar, lots of flour, lots of lard, those types of things, and it resulted in an almost overnight, if you will, increased risk of diabetes, which is why some postulate that you see higher rates of diabetes in those communities.
Well, in those communities, but now we're in a fairly sophisticated community here in Northern California. I just refuse to believe that most people don't recognize the risk factors for diabetes. They're everywhere, and we've spent thousands and thousands, probably millions of dollars trying to educate the community. Why are the rates still so high?
Well, it is difficult. As you know, a lot of it is lifestyle management, so changes in the way that we eat and the way that we live. And you think about how we are today, especially with developed countries like the United States. Many of us have sedentary jobs where we sit in front of a computer for most of the day, and the food that's most readily available to many of us is fast food. It's quick, it's relatively inexpensive. And so when those things combine, you can imagine that you see an entire society developing diabetes at a higher rate than you might have seen, say, 50 years ago, even here in the United States.
You're looking right at me when you describe that kind of individual. So, but now, what about the fact that so many people with diabetes don't know they have it? Mm-hmm. And do you think much of that has to do with access to care, or is it people are just concerned about bad news? What are you finding?
I think it's a combination of factors. Certainly access to a usual source of care, to someone that you trust, makes a difference. We've also done some research suggesting that in terms of hearing messages about obesity from the Centers for Disease Control and other places, that certain groups may be less likely to believe that message if they don't trust the deliverer of the message. Mm-hmm. So we've shown, for example, that Hispanics, low-income people, and a few other groups may be less likely to believe the messages that they hear from certain sources. So that's part of it. But then certainly also we see a lot of underdiagnosed diabetes. I think it's around 16 million people in the United States today have undiagnosed diabetes, which means that they have active diabetes, but they have not yet been diagnosed by a clinician. Now, while some of that may be uninsurance or underinsurance, people simply can't afford to go to the doctor and get the test done. In other cases, it may be miscommunication. So, for example, we found in some of our studies that patients who on the record have diabetes and have a history of diabetes on the record, when you talk to them as individuals, they say, oh no, I'm pre-diabetic. And so there's clearly a communication issue going on there between what the clinicians think they've told the patient and what the patient actually believes that they've been told in terms of their condition.
If you sum up all the information that you've gathered in the area of both obesity and diabetes, what changes would you make if you had come to the global opportunity in WAN to mold the healthcare system?
Well, that's a big question. I think there are a lot of issues. First of all, the quick, easy ones, if you will, are ones where we address issues of lack of insurance and underinsurance. Clearly, we know that insurance helps. Insurance paves the way for people to at least open the door. Certainly, there are barriers thereafter in terms of how you use the healthcare system, but that's a huge barrier for a lot of people. So addressing this issue of underinsurance and lack of insurance is very important. Another issue is addressing some of these barriers that happen to people once they get into the door of the healthcare system. Things like language access, making sure that people actually have access to someone who speaks their language so that they can talk about these issues. Also issues like co-payments, and understanding the impact that copayments have on patients' ability to pay for their medications, to pay for their test kits, et cetera. So it's a lot of different factors, I think, that influence the healthcare system with respect to how we can improve the likelihood that patients will benefit from the care that is available for diabetes.
Well, as a clinician, I can tell you it often is baffling as to why people who understand they have a problem don't deal with it effectively. But we also know that as a physician, beyond the prescription, I don't know what happens. You know, I don't know whether they can get the medicine or not. I don't understand the family as often as I should, and I think we have a lot to do. And I think research like yours, I think, should help us to get some of the techniques that we need for the kind of integrated approach to healthcare that we need to solve some of these problems. So Dr. Alyce Adams, thank you for taking the time from me. I know it's a very busy schedule, and we hope you come back with more research.
Thanks so much.
All right, we'll be right back after this break.